Okay, gang, part 2 of today's lecture is the mental health assessment piece. Just a little mnemonic, always send mail through the post office. So these are the things that you should evaluate when you're looking at a psychiatric mental health assessment. Appearance. Does this patient look disheveled? Do they smell bad? Have they showered in the last week or two? Their speech. Are they talking ragtime? Are they, sometimes you need to talk to a mental health patient for a little bit longer and realize their delusional ideation, or they'll tell you they're having hallucinations. Their mood and their memory. We have a lot of scales that will assess memory, and we always ask about mood. We always ask about thoughts because they're not outward. I can't see them. They're not tangible unless the patient tells you. Their perceptions, again, often we'll have people that are having hallucinations, and they might be somewhat benign, hopefully. And their orientation. You'll hear a lot of what sounds like chit-chat on the psychiatric unit, but we're really assessing a lot of these different things: the thoughts, the mood, the perceptions, the orientation. So there's that ANA again. These are the standards of mental health nursing practice. And look familiar, assess, diagnose, planning, implementation, and evaluation. Let's just talk about the implementation. So nursing is the biggest workforce, and we are a hub of coordinating care. It's very important that you're able to talk to all those interdisciplinary team members. We do a lot of teaching in all venues, especially important in mental health, that you are teaching family members and caregivers to help folks with mental health issues stay in their home. Different therapies. We have pharmacological, biological, and integrative therapies. Prescriptive authority and treatment. So remember, a lot of the way we treat mental health is through meds. So higher level nurses, nurse practitioners, psychiatrists will prescribe medications. We use psychotherapy and consulting with outside entities. So we use a lot of screening tools and assessment tools. There may be obviously our observations, interviews with the patient and their family members or caregivers. There's tools that are checklists, rating scales, questionnaires, and standardized tests. There's a couple of examples of them on here. On my unit, because we're senior behavioral health, we do mini mental. There's a couple of assessment tools in a folder in the clinical section of 602 for psychiatric clinical. So you'll all see different tools along the way, but there's a couple of examples in there. So a comprehensive family assessment. So why do you guys think a family assessment is important with mental health? And there's many reasons that a family assessment is important in mental health. You have to look at the patient's social functioning, and how's the family doing it, the psychological well-being of that person, and also the people surrounding them. It has a huge impact on the family, on their social circle. But also, mental health has a lot of genetic components to it. So here's a genogram that might be used as a tool an assessment tool. And this particular one is just looking at depression and alcoholism, which are directly linked. So you see how they can go through the family tree and kind of determine, oh, you've got a strong propensity for this. So here's some typical family mental health nursing diagnosis. So you're not only treating that patient, but if, you know, even if they're going to be discharged to a facility, it's very helpful to keep family involved. So ineffective family therapeutic regimen management, disabled family coping, interrupted family processes for sure. Caregiver role strain is huge in mental health. So those are just some diagnoses you might see along the way. And these are some interventions for the family. The whole family can go to counseling. They might go separately, they might go together. Promoting self-care activities. So you should, if you're a mental health provider, you should be aware of different things the family can do to promote their own self-care and their family functioning and resilience. So there's support groups and just encouraging them to take time for themselves. Maybe they need some respite. There might be something they can do together with their loved one suffering from mental illness, or maybe they need to do something apart from them on their own and help them strategize ways, because sometimes when you're entrenched in that, it's so hard to see the possibilities. There's a lot of education and teaching. A lot of that relates to dispelling some of the misinformation and trying to minimize the stigma attached to the particular mental illness. Mental health assessment of children really have to pay attention to that parent caregiver child dyad, and also to their age and developmental stage. So you might have a 3-year-old that's exhibiting some symptoms of anxiety or whatever it might be, or post-traumatic stress. So they might not be at an age yet or a developmental stage that they're able to articulate that. So I chose these drawings to go in this slide so you can see we use that as a tool to get across their feelings. So we will also use with children playing, because sometimes they'll act out things that are going on. So for children and adolescent, we're going to assess physical items like that genetic tree, what happened with mom and dad and then their parents. Look at that genetic component. Is there vulnerability there? Neurologic issues, psychological issues, so that mental status examination, it's a form that they fill out. Developmental. So now remember, developmental is different than age. You might expect there to be, certain milestones for a 6-year-old, but this person with mental illness might developmentally be presenting as a 2 or 3-year-old and sometimes it's just in certain aspects. They're acting like a 6-year-old in some ways, but in other ways they're very behind developmentally. And always with children, we're looking at the social component. Well, with all mental health patients, we're looking at the social component, but with children, we heavily rely on the school for a lot of information. That's where they spend a good portion of their time. How are they interacting with peers? How are they doing in their classes? Are they getting to school? Are they, well kept when they come to school? Have they eaten? A lot of those things play into their mental health. adolescents, when they're realizing their sexual orientation, our LGBTQ community has a very high rate of mental health problems. So we need to be aware to screen for that. What's going on with religious things, the community? Are people able to function? Like I said, are you getting to school? Are you getting your homework done? We evaluate for sexual abuse. Sometimes post-traumatic stress will lead to other issues. And then what are their stress and coping behaviors? We want to assess, do they have coping mechanisms? Mental health assessment in older adults, we sometimes have to consider other issues. I had a fun video to show you guys with this part, but assessing delirium versus dementia. Just because when my mother-in-law went in to get her hip done, I don't know, 15 years ago, she was in her 60s. She was very bright. She's witty. She was a mess from the anesthesia. She was. And the doctor just assumed dementia. It was the meds that were causing her to have delirium. It was post-anesthesia delirium, and then they were giving her other drugs that were having an adverse effect, not what we expected them to do, that perpetuated that issue. So sometimes it's medications. This says post-anesthesia. UTIs, it's amazing the change in an elderly person with a UTI. We always check for urinary tract infections. It's standard protocol in my unit. And then you learned about, in med-surg, acid-base imbalance, dehydration, what those can do to someone's mentation. So we have to rule out medical issues, medication issues when we're assessing, and especially with an elderly population. It holds true in other populations. Alcohol and drugs can cause some interesting behaviors and mental health, paranoia and delusions and all of that. So consideration in all populations, but in elderly population, they're more prone to some of those medical issues. So this is just different ways we do our physical, psychological, and social assessments of an older adult. We talked about some of these things with the physical. I don't think I talked about nutrition, but that's very important. And sleep can sometimes be a big issue. Pain can also be a big issue, more so in elderly population than other younger persons. Also, our elderly population, that psychological component, I think the stigma is reducing a little bit. Our younger generation has maybe a little bit more of an understanding about mental health illness than the elder population. So, be aware of that. And then with elderly folk, sometimes their support system is diminishing. Maybe they can't drive anymore, so they're not getting out to people. Their spouse passed away, their children are moved and gone, so their support systems are diminishing, and their function is diminishing. So, we always talk about quality of life when we talk about older adults. You need to assess, how is their quality of life? Are they able to care for themselves? Are they able to enjoy life? We have to talk about suicide assessment when we talk about assessing mental health. This is, believe it or not, the most recent graph that I could find, 2014. And I would be very interested to see a graph in a few years now, because our anxiety and depression rates are through the roof with COVID. So that social isolation, socioeconomic concerns. You see how all those things play into mental health. So our anxiety and depression is going through the roof. But notice here where our highest rates are and how much they've increased from 1999 to 2014. And they're largely in this 45 to 64 population. So just something to think about. Risk factors for suicide. Another interesting chart, but some of the things I talked about, LGBTQ, they are definitely at higher risk for suicide. People that have suffered trauma and abuse along the way. There's genetic factors that play into severe depression, race, ethnicity, religion. So all of those things have a role. So suicide interventions, you just want to ensure patient safety. So oftentimes you have someone that comes in, SI, we call it. They're under constant surveillance. They're constantly monitored. So invasion of patient privacy, yes, but they are a danger to themselves. So some of the things that you'll see, we have paper utensils. Other units might only give people finger food, because if you give them even a plastic knife, they might be sitting in their bed with their arm under the blanket, and you're sitting right in that chair and they're sawing at their wrist under the blanket. So we try to give emotional support. We try to give medications that will help. ECT, I've been told by patients that it's a godsend. We think of, past electroshock therapy nightmares that you see in movies and whatnot. It's come a long way. It's done under anesthesia. It's very tightly regulated, and patients claim that it's extremely helpful. So it's just changing those pathways in the brain to help them overcome what's going on. Teaching them coping strategies is really important. Social skills training. We have people that come in with depression and they just want to isolate. So to try to get them out and learn to be social is really important, because by isolating in their room, they're negating any kind of social support that they might get. And you'll find once they get out and about and they find some social support, that really helps. And then just to mobilize other resources. So that concludes the two areas of content today. Please use that discussion board to ask questions and make comments about the presentations. And I will see you guys next Monday.